Okay, this chapter is chapter 26, the blood. Okay, the different things that we'll discuss here are talking about the different components of blood and talking about the function of each. We'll talk about some terms that are related to how bleeding is controlled. We'll differentiate between the different blood types and talk about their compatibilities. And then we'll also explain the importance of the Rh factor. And then at the very end, we'll talk about a few of the disease processes that are associated with the blood. So when we look at the components of blood, one of the first components we have to look at, obviously, are erythrocytes. So that's the medical term for red blood cells, okay? Two important things that we can determine about the erythrocytes are the hematocrit and the hemoglobin. The hematocrit is the amount of cells in a percentage when you spin down a sample of blood in a small microhematocrit tube. When you spin it in a centrifuge, it actually separates blood into its components. And so the red blood cells will then pack down at the bottom of that microhematocrit tube and give us a way that we can actually measure the amount of red blood cells that exist in within the whole blood of that individual. And so that can give us an idea about whether or not an individual has enough red blood cells and whether or not they're anemic. Okay, and we'll do this in class. The other thing that you can actually do is measure the amount of hemoglobin. Now, hemoglobin is a protein that is located within erythrocytes, and it is the protein that allows the red blood cells to carry oxygen and carbon dioxide. Okay, when that blood cell is carrying oxygen, it's called oxyhemoglobin. If it's not carrying oxygen and or carrying carbon dioxide, it's called deoxyhemoglobin or carbaminohemoglobin. Okay, that just means that it's not carrying oxygen, it's carrying CO2. Okay, we can measure the amount of hemoglobin that an individual has within the system or within the blood, which can also give us a measure as to whether or not that individual has enough red blood cells, whether or not they're anemic. And we'll talk a little bit about anemia later on in the lecture. Okay. Now, another component that is part of blood are called white blood cells. The other name for that are leukocytes, and there are 5 different leukocytes within the blood. 3 of them are called granulocytes: neutrophils, eosinophils, and basophils. And the other group is called agranulocytes, and the 2 agranulocytes are monocytes and lymphocytes. And the reason why they define the difference between these two is when you stain these cells, they will stain different colors. The granulocytes will have a freckled pattern inside the cells, and agranulocytes will not. So that's how you can differentiate between them. The combination of all 5 of these cells equals 100%. So these numbers will rise and fall depending on what's going on within that individual's immune system. If there's an infection present, a bacterial infection, then the neutrophils are usually the cell that are present in the highest amount within the blood at any given time. They will increase if there's an infection or a bacterial infection within the system. And that's because they are like the Marines. They are the first ones on site when there's an injury or if there's an infection present. They will rise sometimes up as high as 70% of the total cell count in order to fight off that infection. Okay. Eosinophils are a smaller amount. They're usually more like 7 to 8%, maybe 6 to 7% of the total white blood cells. They will elevate in a situation where that body has a parasitic infection or if there is an allergic reaction. And they've actually found that in the respiratory tract of some people with asthma, that they have a much higher eosinophil cell count within the bronchus, within the respiratory tree. And so they found that that they can affect and decrease the amount of eosinophils, that it's a way to treat people that have asthma. So there's some new medications on the market that actually attack asthma by decreasing eosinophils. Then we have basophils. They are the least numerous cells, usually about 1% or less. They also play a part in allergic reactions and the inflammatory response. However, they also secrete a small amount of heparin, which prevents all of these cells from clotting together. So it's a very important function that the basophils provide. Then when we look at the two agranulocytes, we have monocytes and lymphocytes. The monocytes are about probably 10 to 12% of the total cell makeup. They're kind of like the army. They don't rise right away like the neutrophils do, but they tend to be a little bit more, they rise longer and sometimes even in higher numbers at times than the neutrophils in response to an infection. So they kind of come in and take over, and so overall they tend to have a more sustained response to fighting off that infection. They kind of take over as the neutrophils drop off. The monocytes kind of particularly will rise in response to viral infections, and mononucleosis is one of the infections where monocytes are primarily high and sustained for a long period of time, because that particular viral infection sometimes takes a couple of weeks to get through. Then we have lymphocytes, and lymphocytes are important because they create antibodies that actually help to modulate that the juncture between our innate immune system to our adaptive immune system. So lymphocytes produce B lymphocytes and T lymphocytes that actually aid in maintaining our immune response and making memory cells, and why our vaccinations are actually why our vaccinations actually work. So now, if we look at more components that we see within the blood, we talked about the red blood cells and the white blood cells. We also have thrombocytes. Thrombocytes are platelets. Okay, thrombo means clot, and cytes are cells. And so blood platelets roam freely. They're kind of cell fragments that roam freely through the blood, and they are there just in case there's any kind of trauma within that blood vessel, so that they can immediately plop onto that area or attach and create a natural band-aid. Okay, and so that's what those thrombocytes function to do. Then within the blood plasma, we also have very specific blood plasma proteins. There are 3 of these proteins. The first one is albumin, and albumin is the smallest protein, but it's very important because it helps to maintain our osmotic pressure within our blood and also maintain our blood pressure. And so those albumins, the higher the albumin level, the more water it will pull in from the surrounding tissues into the bloodstream. And if there's less albumin, then you can actually get rid of water that way. So it maintains our osmotic pressure within our bloodstream. Globulins are important because they also form antibodies. Immunoglobulin or gamma globulin are forms of antibodies that actually help to aid in our immune system. The globulins can also transport lipids and are fat-soluble vitamins. Vitamin A, vitamin D, vitamin E, and vitamin K are all fat-soluble vitamins. Then we have fibrinogen. Fibrinogen is the protein that is actually responsible for the blood clotting process. Platelets provide a very immediately quick, kind of a natural band-aid, and then that allows for fibrinogen to come in and be converted to a protein called fibrin, which actually allows a foundation that creates a blood clot. And then that triggers fibroblasts to come in and start repairing the area. So we go from a thrombocyte or a thrombocyte platelet plug to a fibrin or fibrinogen blood clotting process. So that's kind of that extensive chemical process that allows that to happen. And when we're looking at these when we're looking at these components, we talked about the red blood cells, then we looked at thrombocytes and white blood cells. They make up something called the Buffy coat, and we'll actually see this when we do our capillary punctures and spin down the blood and take a look at these components. We'll actually see that. So on top of the Buffy coat is something called plasma. And plasma is the liquid portion of blood. It's primarily water, 90% water, but there are also the plasma proteins, there are nutrients, there are electrolytes like sodium, potassium, and hydrogen, and also waste products like urea and creatinine are within the plasma. Another word that's important to understand is the difference between plasma and serum. So plasma is the liquid portion of blood. Serum is the fluid that is left over in the plasma when you remove all of the clotting products. So plasma includes the clotting products. Serum is when you take those clotting products from the plasma, and that's what's left. And a lot of our basic lab tests that we do function off of doing those tests from serum. We remove all the clotting factors, and then we do a lot of different chemical analysis on the serum. So if we have bleeding, we have to find ways to be able to control bleeding. And so the word that's used for bleeding control or stoppage of bleeding is hemostasis. Stasis means to stop. Hemo refers to blood. And so there are 4 different processes that are involved with this. And there's blood clotting is a very elaborate chemical process that occurs. So we're not going to talk about that here. But one of the first things our body will do if there's some sort of damage to a blood vessel is the blood vessel will spasm in response to serotonin and a couple of other chemical hormones. That spasm is designed to try to get the area to stop bleeding. If that doesn't work, then within about 15 seconds, all the free floating platelets that are within the blood then attach on to that area that is damaged and cause a quick band-aid. It's called a platelet plug, okay? From that point, that band-aid is there to help decrease the bleeding. Then we have the fibrinogen that's roaming around in the plasma as well, is then drawn to that area, and it is then converted in a very elaborate process to fibrin, which is actually the sort of the clotting process. So that fibrinogen is then converted to fibrin. Then that allows new fibroblasts to come in and start laying down more new tissue to repair that area, okay? And so the word coagulation is actually referring to the formation of a blood clot, okay, where that plasma protein fibrinogen is replaced by fibrin. So first we get a platelet plug that's very rapid and very quick. And then within 15 seconds, we start having the blood clotting process occur. So there is a difference between hemostasis and coagulation. Hemostasis is just the stoppage of bleeding or bleeding control. Coagulation is the formation of a blood clot, okay? Then when we look at these red blood cells, there has to be a way to generate the formation of new red blood cells, okay? Red blood cells are the only cells within the human body that do not have a nucleus, so they cannot reproduce on their own. And so the red blood cell's lifespan is about 90 to 120 days. So that means the body has to constantly be turning over these red blood cells in order to maintain the oxygen to the tissues that we need in order to survive, okay? And so we have a process called erythropoiesis, and that is the formation of new red blood cells. If we talk about the formation of blood in general, you'll hear the word hematopoiesis. But when it's being referred to specifically with the formation and generation of new red blood cells, we use the word erythropoiesis. Poiesis is the formation of. There's a hormone that is secreted by the kidneys called erythropoietin. And when the kidneys sense that there's not as many red blood cells in the system, it is then stimulated. The kidneys stimulate that hormone erythropoietin to be secreted, and that actually signals the red bone marrow within the bone to start to create more red blood cells. Okay, that can happen because of low oxygen levels, or if the red blood cell lifespan is turning over, then that hormone is constantly secreted in order to maintain the number of red blood cells that that individual needs, okay, in order to maintain the amount of oxygen supply that's necessary to keep that individual going, okay. Now, the other important thing to discuss is blood typing. And this can be confusing, and we'll talk about it in class a little bit. but there are four blood types, and they call it the ABO blood group: A, B, AB, and O. And there's also a positive or negative that's attached to those, and we'll talk about that in just a little bit, okay? So if you have type A blood, then what that means is all of the red blood cells within that individual have a little marker or antigen on the outside of the cell, which is a marker A, which identifies it as type A. And that's on every red blood cell surface within the blood. Antigen A means that that individual is used to seeing that blood type within its system. But if blood type B were to be introduced into that blood type, then it would create an antibody towards it because it's not used to seeing it. And so antigen A has antibodies in the plasma to type B. Type B blood is the opposite. They have that name tag or antigen marker B on the outside of all of its red blood cell surface. And so it would create antibodies to A. And so they have antibodies to A within the plasma. Okay. And the important thing with this is you can't give someone the wrong blood type. Okay. Because it's not used to seeing that particular blood type. If it's never seen it before, it's going to make antibodies, and then it's going to cause a hemolysis process. And we'll talk about that in just a minute. Okay. Then we actually have some individuals that have both A and B markers or antigens on the outside of their red blood cell surface. They're very special. They have both of those. And so because of the fact that they have both of those markers, they don't make any antibodies to A or B in their plasma. Okay, so they have those two antigen markers on their cell surface, so they make no antibodies to A or B. Now, type O could be kind of considered type 0 because they have no antigens. There's no markers that identify what that particular blood type is. They have no antigen A and they have no antigen B, okay? So that means they have nothing on their cell surface. But what that means is that if you were to give someone type O blood, if you give them type A or type B, they're going to react and form antibodies, okay? So type O blood has no antigens, but because of that, they'll make antibodies to both A and or B if those particular blood types are introduced to that individual, okay? And the process where that reaction occurs, if you give someone the wrong blood type, you get a situation that's called an antigen-antibody reaction, okay? And that term is called agglutination. And that agglutination is an abnormal lysing of the blood that's given or the donated blood that is incorrect. This is also called a transfusion reaction. So the importance of determining blood type before giving someone blood is very important. Now there's one more little caveat to this. We have the ABO system, but then we also have positive or negative. And so there was a protein that was discovered during the study of rhesus monkeys that found that there was another marker on the outside of some cells called the Rh factor. And that is an additional antigen or protein that's located on the outside of red blood cells. If an individual has the Rh factor, then they will have a positive attached to the letter. If they do not have the Rh factor, then they will be considered negative. About 85% of the population is actually positive and about 15 is negative, okay? And so when we actually look at an individual that is considered a universal recipient, what that means is that person can accept any blood type and they will not have a reaction, okay? So AB positive is considered our universal recipient because they have the A antigen, the B antigen, and the Rh antigen. All of those are there, so they make no antibodies to anything, so they can receive any blood type. They can receive A positive, A negative, B positive, B negative, O positive, O negative, and AB. They've seen all of it. They don't make any antibodies, so they can receive it. O negative is considered the universal donor, and that is because they have no antigens at all. Okay, and so that blood can be introduced to any blood type and it will not react because they have no antigens. Okay, now some people kind of think, well, why isn't O positive the universal donor? Well, because it's got the positive there. If you give O O positive blood to someone that's A negative, they've never seen that positive before, and they're going to have an agglutination or a transfusion reaction. Okay, and so O negative has no antigens, so it can donate. A positive or AB positive has all of the antigens, so they can accept anything. And we'll go through this in class a little bit more. We'll actually determine your guys' blood type in class as well. Okay, and this particular Rh factor is very important when we're actually looking at females of childbearing age. Okay, because if a mother is actually Rh negative, and we're not really looking at the ABO part, we're just looking at Rh negative, and has a child with a father that is Rh positive, there's about a 50% chance that that fetus will be Rh positive. And so what happens is, because the mother's blood intermixes, or the baby's blood intermixes with the mother, the first child generally isn't effective. What happens with that first child is that the blood becomes like put on alert. And so the mother's blood's like, gee, we've never seen this before. What's going on here? But nothing really happens. Okay. But the problem is with subsequent pregnancies, then if you have a child with the same father or another father that's Rh positive, then that blood will then be on alert. It will now attack the baby's blood, and it can create a very, very severe anemia called erythroblastosis fetalis. Okay. And so that's why it's really important. All women go through blood typing. They must know what they're dealing with, so that if there is an issue, usually if we have an Rh positive or an Rh negative mother, generally they'll talk to the female and try to get the blood typing of the father so they know what they're dealing with. And it helps kind of determine the process of care. And so there is a shot called RhoGAM, and it is sort of artificial Rh factor, and it kind of prevents the production of maternal antibodies with subsequent babies. So if we have an Rh negative mom, most moms will get a shot with any bleeding in the first trimester if it happens. If it's not, they give them one about 28 weeks, and then one postpartum. And what that's supposed to do is kind of prevent the mother from making antibodies against the baby that might be positive. Okay. All right. And so the book, there's lots of different blood disorders that we could go through, but the book kind of focuses in on these 5. And so the first one was anemia. And if you look at the anemia area, there's a lot of things listed under anemia. Okay. And so anemia is basically a condition in which the person doesn't have enough hemoglobin or red blood cells to carry adequate oxygen to the tissues. And there's a number of different things that can result in this. Okay, the most common, probably percentage wise, is iron deficiency. Okay, that can be from that can be from blood loss. Okay, um, and so primarily we see that with females with menstruation. Okay, you don't see too much iron deficiency in males. It can happen, but not very often. Okay, and so um, chronic blood loss, certain vitamin deficiencies, vitamin B12 and folic acid are very important in the production of red blood cells. So if there is something where there's a lack of B12 or folic acid, then the body cannot make enough hemoglobin or red blood cells, and so that can lead to anemia. Chronic illness can also be a result of anemia. AIDS, cancer, some of the leukemias can all cause an anemia or a chronic anemia of illness. And so it can be difficult to combat that kind of anemia. There's some artificial erythropoietin called Epigen that will sometimes work with people that have chronic illnesses to help boost their red blood cell number. Lack of intrinsic factor is something that happens in the geriatric population. Intrinsic factor is necessary for the absorption of B12 in the digestive tract, and so it tends to be something that happens in older individuals. But that can be a source of anemia, and it's a specific kind of anemia called pernicious anemia. And then we have certain conditions where there's hemolysis or destruction of red blood cells. Sickle cell anemia is one of those types. And then we also have some bone marrow abnormalities. With some of the leukemias, we actually find anemia as well. Okay. And so the book does go into a little bit more depth of those, but those are all possible causes of anemia. And if we have anemia, we either have a low hemoglobin, um, we either have a low hemoglobin level or we have a low red blood cell pact level. Okay. Then we actually have sickle cell anemia, and that is an inherited disorder where we have an abnormal hemoglobin, or if the formation of the hemoglobin is abnormal, the protein chain that makes it up is different, and what happens is it causes, rather than having sort of a discus shape red blood cell, the red blood cell collapses into a crescent shaped, or what's called a sickle shape. And what the problem with that is that they don't those cells don't bounce off each other and they don't flow well through blood vessels. And so when you get to the smaller vessels like capillaries, then they start to stick together. And then you get intense pain, where you actually have sickle cell crises, and it's a very painful situation, and it can be very difficult to deal with. There really isn't a cure for it. You basically have to um, kind of relieve them symptomatically, um, and it really increases the risk of infection and certain arthritises, and so it can be a very difficult anemia to treat. Okay. Then we have thalassemia, and so thalassemia is an inherited form of anemia from also a defective hemoglobin chain, but it actually causes a situation where the cells are microcytic or smaller than normal, and they're hyperchromic. Now remember, chromo means color and hypo means less. So they tend to be more pale colored cells. And because they're microcytic and hypochromic, they tend to be very short-lived and lyse very quickly. And there are different degrees of thalassemia. There are some there's a thalassemia major and a thalassemia minor. It's usually the people that have the major component that are more affected. Um, but there really isn't any treatment for this particular form of anemia either. Then we have leukemia. Now, leukemia is basically cancer of white blood cells. And so this is a condition where the red blood cells within the bone marrow produce abnormal or abnormally large numbers of white blood cells, but they are immature. And so something within the system is making cells at a much faster rate, and so they tend to have high numbers of white blood cells, but they don't work. They're immature. And so they aren't effective at actually fighting off infection. And because the white blood cell number becomes so enlarged, it tends to cause the red blood cell count to decrease, which is why a lot of people with leukemia get anemia as well, because the white blood cells the number increases tremendously within the system, but they're not mature enough to fight off an infection, and it takes the place of a lot of those red blood cells, and so those individuals become anemic in response to that. And once again, we have to go through, there's lots of different signs and symptoms that go along with it. Just doing a simple CBC can actually detect whether or not somebody has leukemia. They then oftentimes have to go through a bone marrow biopsy, um, with, with a bone marrow transplant, radiation and chemotherapy. But there are a lot of consequences that come from, and there's a number of different kinds of leukemia, which the book doesn't really talk about, but it's definitely one of those cancers that we've come a long way with treating. And then we have a condition called polycythemia vera. And polycythemia is where we actually get an abnormal increase in the amount of red blood cells. We just talked about leukemia where we get less. This is a condition where we actually get more. And so there can be a genetic mutation that causes this, but it can actually and it can come from a response from living in higher altitudes. If we live in higher altitudes where the oxygen percentage is less, then the body, in response to that, will actually create more red blood cells in order to compensate for that. And so what happens is the blood gets thicker. And so these people have a tendency to be short of breath, dizzy. Their spleen becomes large because they're trying so hard to reproduce so many red blood cells. And so we actually have to treat these people with periodic venipunctures um, to actually decrease the amount of red blood cells within their blood. And so when that blood gets thicker, the heart has to work harder. People can go into heart failure if they have prolonged polycythemia. Um, and so the therapeutic blood draws or therapeutic phlebotomy is usually the way they treat this. Okay. All right, so that goes through some of the things that we talked about. This just gives a little summary of the blood so that as you guys go through the other chapters, or as you go through chapter 48, and we'll be doing venipunctures and some of the different tests that are associated with I'm sorry, not venipunctures, capillary punctures. We'll get venipunctures next semester. So we'll go through and do some different tests that are involved with capillary punctures, and this will at least lead into chapter 48 and the information there. So I'm going to sign off, and I'll see you guys in chapter 48.